So it is a subspecialty like breast, like gynecological pathology, genitourinary, GI, whatever, but it's a small niche specialty.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Hadi Saheb and myself, Heather O'Donnell. Season 5 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado EyeCan vous est offerte par Bayer. Nous les remercions pour leur soutien. We will be sharing our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers.
Dr. James Farmer is an Adjunct Associate Professor of Ophthalmology and Pathology and Molecular Medicine at Queen's University in Kingston, Ontario, and an Assistant Professor of Laboratory Medicine, Anatomical Pathology, with a cross-appointment in Ophthalmology at the University of Ottawa in Ottawa, Ontario. Dr. Farmer graduated from the University of Ottawa Medical School and completed his residency also at the University of Ottawa, and then a fellowship in Pediatric Ophthalmology, Strabismus, and Pediatric Neuro-Ophthalmology at the Smith-Cattlewell Institute of Visual Science in San Francisco, California, at the University of San Francisco. Dr. Farmer completed residency in Anatomical Pathology at the University of Vermont in Burlington, Vermont, and University of Ottawa. He is section chairman of the Canadian Ophthalmic Pathology Society, section editor for Ophthalmic Pathology for the Canadian Journal of Ophthalmology, and a member of the Eastern Ophthalmic Pathology Society based in the United States. Dr. Farmer, welcome to EyeCan. Let's get this conversation started. It's a great topic for our listeners to learn more about. I feel like every time I'm talking to a pathologist, I feel like your answer, your ability to get the answers for a patient often depends on what we send you.
Correct.
Whether that's the medium or the history. And I think I'd be remiss if I did a podcast and not asked you about that.
I've got some stories, to say the least. The communication is probably the critical thing for patient care in any realm. As a comprehensive ophthalmologist, I spent my entire career dealing with patients and dealing with the ability to tease out information, be efficient or whatever. And then when I streamline consults, for example, as we all do as specialists, you prioritize your ability to see the patient and the timeliness based on what information you get. A surgical pathology report is exactly the same thing. If there is little information in, the pathologist is left struggling, trying to figure out what it is exactly being looked after or whatever. And that can create real problems. And sometimes it leads to inadequate results. As I said, the thing we need to remember is a surgical pathology history is our consultation note. If you send me a patient who's got a tumor on the eyelid and you say, there's a white mass, been there for 6 months, now rapidly growing, whitish in color, interfering with the patient's vision, strongly suspect a basal cell carcinoma, for example. If I get your biopsy and I get for 2 or 3 levels and I don't see a basal cell carcinoma, I'll cut deeper into the block to look for it. If you send me suspicious lesion, believe it or not, or please examine, believe it or not, guess what happens? I've got a stack of work to do, just like having 40 patients on my waiting room wondering when I'm going to see them before their parking drives them crazy. And I may not decide I'm going to cut into that block. I'm just going to say, well, I don't see anything here, non-diagnostic, go back and take more. So, and this also addresses the issue that I was talking about not having specifically trained ophthalmic pathologists.
Oh, I love this. Okay, we're going to get into this. We'll back up a little bit. So let's start with defining the field. So ophthalmic pathology sits at the intersection of pathology and ophthalmology, and it plays a crucial role in diagnosing and understanding diseases of the eye and nexa. And I think we should go back and talk about an overview of what ophthalmic pathology really entails and how it's different than general pathology. And then we'll work into this idea of the sort of who our ophthalmic pathologists are in Canada and where our next ophthalmic pathologists are coming from.
Well, I think
why don't we start with sort of that, how is this different than general pathology? And tell us more about the field of ophthalmic pathology.
Ophthalmic pathology per se now is a subspecialty of anatomic pathology, or as we have now been renamed, diagnostic and molecular pathology. The Royal College has taken away anatomic path, and we are now diagnostic and molecular pathologists. So it is a subspecialty like breast, like gynecological pathology, genitourinary, GI, whatever, but it's a small niche specialty. And I say especially small and niche because most departments don't have a large volume. So it's not like a full-time workload for a pathologist. And the eye is very different than just about any other tissue in the body from a pathologist's point of view. They don't necessarily spend a lot of time on the anatomy of the eye or the particulars of the orbit, et cetera, like they do when they're doing their pathology training. Autopsies are part of their training, right? So they do systemic examinations all the time in their training, but they don't ever take an eye at the time of a general autopsy to learn more about the specifics. So the specifics of, the uveal tract, the retina, the soft tissues in the orbit becomes each with its own diagnostic issues, is something that's foreign to many anatomic pathologists. And don't forget too, like we have, 4 years of intense training to become an ophthalmologist after our R1. The general pathologist and diagnostic and molecular pathologist has 4 years to learn all parts from neuropathology right down to pediatric pathology to everything. So ophthalmic pathology is required by the Royal College as a knowledge source to be examined on. But many programs don't have an ophthalmic pathologist. Those residents don't get the training that they should. And training is limited primarily to those that are interested other than lectures. For example, I lecture the anatomic pathology residents both in Kingston and in Ottawa on ophthalmic pathology. I try to stir up interest at the same time for them to come and do rotations in it with the future, because the future of ophthalmic pathology in 2025 is in the realm of diagnostic and molecular pathology. It is not from an ophthalmology point of view. Traditionally, as I talked to you briefly before, it was ophthalmologists interested in becoming an ophthalmic pathologist, going to the FIP, and then going back home and then being able to do cases.
Tell me again what that traditional pipeline was. Who were those original ophthalmic pathologists? Because it does have this kind of interesting, unique history of of that trajectory. How did it work? Explain it to our listeners.
Not wanting to go very back to the basics, but if you look in North America, for example, and in England in the 1950s, there was 2 pathologists, Norm Ashton in London and Lawrence Zimmerman. Lawrence Zimmerman, interestingly, was the American. He was an infectious disease pathologist who was working at the FIP, and they walked in and said, "Hey, we got this backlog of cases. How would you like to be an eye pathologist?" Boom. And that was it. So
how things happen sometimes, right?
Well, how fortunate it happened.
Right.
And then he built up this very, very strong department at the Armed Forces Institute of Pathology in Washington, D.C., with a huge volume of cases and a consulting service that rivaled none. Because the other thing the AFIP did was it had a consulting service in every major subspecialty in anatomic path. So if you wanted to specialize in GI pathology or genitourinary pathology, many went to the FIP for that special training, and then they went elsewhere, and then they built up their own practices things. So Zimmerman stimulated this proliferation of ophthalmic pathologists in Canada and the United States, most of whom were ophthalmologists.
Okay, so if I was an ophthalmologist in the 1960s and I was doing some orbital tumor removals, and the team that happened to be available to me within Canada just didn't really understand or was struggling with the nuances of this pathology, I might say, I, as an ophthalmologist, am going to go and train in one of these places, acquire this knowledge.
Yes.
And then I would bring it back. And
yes.
How did that look? It was sort of fellowship after you were originally trained.
Precisely. It was after you did your ophthalmology, you could go do a year or 2 fellowship at the AFIP, and then you would come back. And then slowly there were a few, especially the movement became in the States, that again, ophthalmic pathology was not remunerated to the ophthalmologists. It had to be remunerated through pathology because they're pathology specimens. And that became even tighter when the Royal College and the American colleges decided that only pathologists can sign out pathology. So all of these ophthalmic pathologists who were ophthalmologists, who were trained in just ophthalmic pathology, had to partner in their department with another pathologist to sign out their material. Most of them were neuropathologists, maybe a dermatopathologist, but they were courtesy because this person had the expertise, put their name on it, it was done. But as that's evolved over time, the pathology department is going, well, wait a minute, why is this person in here? We should look at maybe getting that expertise in diagnostic and molecular pathology as it evolves. And so now what has happened, and particularly in the States, to be an academic ophthalmic pathologist, in most institutions, you require double certification. So therefore, then became the trend to either do your ophthalmology residency, then go and do a second residency in anatomic pathology or now diagnostic molecular, like I did, or you were an anatomic pathologist who then went back and did a residency in ophthalmology. And prior to the matching services and the volume of people feeding into it, it wasn't a terribly difficult thing to do in the 80s when I did my dual fellowships. And in the 90s, it's a little more challenging now because of limited residency spaces, et cetera, et cetera. So it's not as easy for that to happen.
Are you worried about this?
Yes, I am, because it is a very specific niche subspecialty. It doesn't take up a lot of workload from a pathology department's perspective. They don't necessarily assign a lot of importance to training somebody to do this unless you're in a center that has a large volume. So Ottawa, Vancouver, Calgary, Edmonton, Toronto to a degree, but that's a whole nother issue that can be discussed another time. But I mean, they look at it, well, we got to have somebody do this thing because it's not something that can necessarily just be subdivided, which happens in other departments where they don't have a specialized ophthalmic pathologist, where if it's an eyelid tumor, it goes to dermatopathology. If it's conjunctiva, it goes to dermatopathology. If it's an orbital tumor, it goes to soft tissue. If it's a lacrimal gland tumor, it goes to head and neck. So if it's a lymphoma, it goes to lymphoma people. So you can see how this becomes very disconnected. And it makes it difficult for clinicians because then you don't really know who you're talking to, right?
Yeah, we don't know who to call when the diagnosis.
You don't know who to call, right? When you're dealing with this. And there are certainly diagnostic cases that are pretty specific to ophthalmic pathology. One of the biggest ones, and one of the headaches was sebaceous carcinoma is a good example of the eyelid. I mean, it's seen elsewhere in the body, but most frequently, sebaceous carcinoma is a disease of the ocular adnexa, right? And dermatopathologists, many, and anatomic pathologists in the older days, were reluctant to ever make that diagnosis because before we evolved into the fact there is in situ disease, there is map biopsies that can be done to plan out it. They were concerned that if they made a diagnosis of sebaceous carcinoma, the next thing they know, they've got an exoneration with an eye sitting at them. So there was a reluctance to want to make a diagnosis because they didn't feel comfortable with not knowing what was going to happen. That's the role of an ophthalmic pathologist, somebody who is especially trained in ophthalmology and trained in pathology, or at least does it exclusively enough to see what the outcome of our diagnosis are to make you feel, yeah, this is what it is. I'm not going to be worried that if I make a diagnosis, I'm going to do harm to the patient by a treatment that I am not familiar with. And all of pathology, to be honest, has evolved into tumor boards and subspecialty clinical pathologic correlations. So, you know, if it's a breast carcinoma, the breast pathologist is there with the breast surgeons and the oncologists. I mean, it's a team effort. Well, ophthalmic pathology in its own way is somewhat the same thing. But if you don't have that special knowledge of what's going to happen to the patient, what the clinical significance is, et cetera, it can lead to a reluctance or misdiagnosis or whatever. And I think one of the biggest things, as I alluded to earlier, is that there's a concern because our tissue biopsies are small, especially conjunctiva, and corneal biopsies for certain things other than a keratoplasty, that if you don't section it enough or you don't investigate it enough, you'll miss what you're looking for. And one of the things that ophthalmic pathology, when I train the residents is, if an ophthalmologist sends you a pigmented lesion on the surface of the eye and your first 2 or 3 levels don't show pigment, you better keep looking because an ophthalmologist is not going to take a piece of conjunctiva just for the heck of it. So, and I've seen this, I've seen melanoma show up on level 15. We've seen melanoma show up on level 20, where if you quit at 5, you're done. And the problem in not having this dedication is if you're in a private situation where you send your stuff to a private laboratory who's got a dermatopathologist who's looking at this, and he looks at, or she looks at 3 or 4 slides and says, oh, there's nothing here, gone. They are processing 25,000 specimens a year personally, or some crazy number that they often don't take that extra time because it's the remunerations and everything are different. So ophthalmic pathology brings to the table the expertise of ophthalmology specific to the patient's needs to get a proper outcome. And the other thing is we are closely allied with ocular oncology. And so many of the overlaps between oncology and pathology and research and developments that have promoted both fields are closely intertwined. So interesting you mentioned, I've been doing this. Well, so I like to tell my residents I'm a PGY 46 in ophthalmology and 32 in diagnostic and molecular pathology. I love our new term, DMPs. We're all DMPs. That for the first, 10 or 15 years, there was the occasional ophthalmology resident that was interested, well, I should say medical student who was interested in getting into ophthalmology, who would want to do ophthalmic pathology to get a bit broader base, but also to help their application. But from a resident perspective, there was always the buy-in because of the Royal College. If you don't examine something, there's little interest for many people to really want to learn it, right? Yeah. Even though it's a core knowledge and it's critical, I'm a pragmatist, right? Mm-hmm. So you got to know it for your exams. You got to know it for the OCAP. You got to know it for the Royal College. So therefore, that is that stimulus among residents to want to be able to pass and to have a core knowledge of all of these things. But recently, I'd say in the last 5 or 6 years, I've seen a swing towards residents inquiring about how to do ophthalmic pathology when they're finished. Mm-hmm. And unfortunately, other than the really dedicated person, because pragmatically, if you're going to do it from an ophthalmologist perspective, you have to do an AP residency, mm-hmm. which is not hard. It's a lot to learn, but it's not as taxing, let's say, as being on call every third night, up all night, whatever, right?
But it's time consuming, and the time that people take to get into the programs now,
precisely.
And the time that ophthalmology residency now with internship, 5 years, they finally finish that. I think people get exhausted. So we're draining our pipeline a little bit, and that certainly is concerning.
Well, and I would argue too, with a people power perspective, it's probably not the wisest use of resources necessarily. However, one has to then keep in mind that if we don't get enough diagnostic molecular pathologists involved, this from a resident on through, or convince our colleagues in diagnostic and molecular pathology to pick this up, we're going to run into this differentiation into multiple subspecialties picking up our work. And I don't think that's a reasonable perspective.
So let's get into this. How do we solution around this? One of my questions for you is about kind of advances in the field and whether or not maybe there's some stopgaps here around new emerging technologies, whether that's advances just in the technologies within the field that you're utilizing for diagnostic purposes, or, everybody loves to ask physicians of all stripes, is AI going to help us? Mm-hmm. So do you think that there's some ways that advances in technology are can fill some of the gaps that might be left by some of our human resource challenges?
Well, I agree. I do think that it's becoming more glamorous because it's now directing patient care. One of the biggest arguments, even when I was a medical student, about pathology is, well, yeah, you're just dealing with dead people. People are dying to see you. But that's not really the case when you go into surgical pathology. And
now, Dr. Farmer, I just want to say the people dying to see you joke. Yep. You would have been horribly upset if we'd made it through the podcast and you didn't.
And I had not thrown that in.
I'm really glad you did it. I'm glad you dropped it early on. And so
you have to get it out of the way.
You got to get it out of the way. I really appreciate that.
That's right. But I think the thing is that it's always been in the background. It's not been something that's been out and flashy or whatever. And when you're certainly going through medical school and you get your lectures on pathology, that can be as boring as anything. You don't see it. But when you actually sit down to I ask medical students, even when I see them doing their rotations or their electives trying to get into ophthalmology, I said, hey, you ought to just sit down and take a hard look at pathology just as a second option because, when I get a typical patient day of, because I'm getting older, maybe 30 patients or so a day. Yeah. The difficult thing to be a comprehensive is screening out who's sick and who isn't, and then knowing when they're sick and how to manage it, as opposed to a specialist who's got only one little area to look at. It's easy to not see what you're doing and to get lost in the numbness of the 90% that are normal. When you sit down to a surgical pathology sign out, I can guarantee you that you sign death certificates in a horrible tumor that somebody didn't know they had, or you've made them the happiest person alive because that little bump wasn't a malignant melanoma, was just a fibrous histiocytoma. And that's a daily occurrence for all diagnostic and molecular pathologists. We may not see the person on the other end, but when we render a diagnosis, that changes people's lives. And when you see a resident, you instill in this. So even though you're not dealing with patients, and luckily pathology specimens don't don't have to pay parking. I mean, you immediately could see them sort of light up, go, yeah, really. And now, certainly we are all familiar with the molecular genetics of tumors and how when you have a conjunctival melanoma, we know conjunctival melanomas are not like uveal melanoma, like cutaneous melanomas. So when they metastasize, or if they're of a certain size, and they're BRAF positive, which 60% are, they respond to BRAF inhibitors. So immediately you have then directed the treatment for that patient by making the diagnosis of a conjunctival melanoma and doing the BRAF molecular genetics. That's done in the pathology laboratory. Right.
Yeah, it's an incredible part of the patient journey now in a way that has really evolved.
So, correlating back to my original discussion about where I could see this going is the few, really interested residents, I would like to encourage them to do a pathology residency. However, if you really are interested and you want to get this involved, ocular oncology to me is a solution.
Okay.
Because as an ocular oncologist, you will be working hand in hand with an ophthalmic pathologist of some degree of training or whatever, or even you can pitch in and then you can help out like the old ophthalmic pathologists were, right? The ophthalmologists who did pathology. As an ocular oncologist, you are intimately involved with the working of an ophthalmic pathologist. So those two specialties blend very nicely. And then the concept of AI is another thing. I mean, the one thing that pathology is changing now is that probably within 5 years, I think in Ottawa and our laboratory within 2, we're going to be totally digitized. So all of the material that comes in from pathology, from the surgeon, will be processed, put on a glass slide, and then the image will be digitized and it'll be sent to my computer. So I could look at it in my office in Ottawa. I can look at it at home. I can look at it anywhere I want. And we will use that as our initial screening tool. And AI in pathology is in the process of potentially revolutionizing pathology delivery. There have been tremendous studies showing that it picks up sentinel node metastasis in breast cancers better than pathologists. It's shown that it could pick up mitotic figures in certain tumors more accurately than a diagnostic pathologist. I mean, and cytopathology, where it can screen cervical smears way more efficiently than cytopathology technicians or whatever. I mean, the studies are out there only going forward. Ophthalmic pathology per se hasn't quite hit some of these larger studies, but we're just a step behind. And what they're hoping the future of AI is not necessarily to ever be a standalone, we don't need a pathologist, but to assist the pathologist in, again, kind of like it'd be the perfect thing in comprehensive ophthalmology to have an AI eliminate the 80% of people that are normal with a minor complaint and pick out the 20, then you spend your time with. So that's what they're proposing for AI in pathology, is to screen the material as it goes through with the digitized slide and then be able to decide, there's this area of the tumor you better concentrate on. There's this particular count that you better look at. And immunostains, which is another huge, advance in pathology in my career, to pick out what the type of tumor it is. Sometimes you can use a molecular marker as an immunostain. AI can screen these things. So that is another way to engage younger people into technology, carrying them forward into their career. But again, as I said, from an ophthalmic pathologist point of view, if an ophthalmology resident was really keen, it does mean setting aside a part of your life to do pathology. But it's interesting, in the States, it's not an issue. I mean, most of the members of the Eastern Ophthalmic Pathology Society that I know who practice pathology at larger institutions are all dual certified.
Okay.
Most of them started as ophthalmologists first and then went back and did pathology as a second residency.
That's so interesting. I'm sort of I'm awestruck by that commitment because it is so much time and training, depending on the workplace dynamics, I can see how maybe it makes sense depending on, academic appointments and career trajectories and such. Maybe it's just a bit of a different milieu. EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
I'm Matthew Benson, and I listen to the EyeCan podcast.
I want to not leave this AI topic because you said something that I reflect on a lot when I get asked this question, and I think it's so important to highlight in this conversation. So you've talked about these things that AI can do, but I noticed something about the way that you were talking about your work and the way that the information that you're giving when you're reading it is really centered around a patient and the experience with that patient and the experience that the patient's going to have. And I think that there's something in that connection, both with the understanding of the impact that the specimen has that reflects a sense of urgency or perhaps a need for communication or some sort of nuance about, oh yeah, and this was the one that Heather called me about that was growing particularly fast and that she felt it didn't totally capture it in the history. And I think that that's the thing that AI isn't going to do for us, is the nuance of really understanding the context of our patients' lives, the urgency of certain diagnoses, our ability to prioritize and shift our frames when needed to focus on one thing and not the other. What do you think about that?
No, I totally agree. I think one of the more there was an interesting article in Histopathology in 2023 that was basically talking about the pros and cons of artificial intelligence in anatomic pathology. And I like the term that they coined, which is augmented intelligence, AI, which is the human and the artificial intelligence working together to be able to come together. I mean, and it's interesting in pathology as well, which I've always struck me, like from the time I was a resident back in the 80s in anatomic path, there was never a case that I signed out as a resident that a staff pathologist did not look at. I mean, we are used to in clinical ophthalmology letting our residents see emergency patients and discharge them if it's blepharitis, if it's a low-grade uveitis. We don't see those patients, right? But in pathology, never does it happen that an anatomic pathologist does not review that slide. And you know why? Because that slide's around forever, right? So if the resident signs a case out and you are the signing pathologist, means you're in charge, and something goes south, a pathologist anywhere around the world can pick that slide up or that block up and look at that case. Whereas in clinical medicine, we're all very familiar with temporal evolution of disease. So that's why documentation is so critical in what we do in comprehensive ophthalmology or any specialty in medicine, because what you write down is what you saw at the time. That can change within an hour, right? So therefore, the coast sometimes that happens is, well, the resident saw it, did the best. 6 hours later, things have deteriorated, right? I wasn't there originally, right? But in pathology, that slide's there forever. Yeah. And so as I also tell my residents, if you look at a slide and you're not sure what it is and you think you should order a level, just remember that the pathologist for the plaintiff will cut through the block.
Okay.
It's a bit of an exaggeration, but it just brings to the point that we as pathologists are very specific about never allowing things to go out of our sphere because we're responsible. If AI comes into an anatomic pathology department or diagnostic molecular pathology, the pathologist they're still a human being who is responsible for that case
Responsible for
going
that
out.
stuff.
And
No
I
question.
cannot see it ever being that if a human is responsible for the work of a computer, they're not going to review something. I mean, so augmented intelligence, I think, is the best way to look at AI, where
I
it's a
like that a lot.
combination of a machine making it easier for us to do our work, maybe picking up things that we may not get because we're all human, but that it's a cooperation. It is not an exclusion.
Okay, that's great. I like that reflection a lot. I want to ask you, rather than asking you about some specific pathologies or some clinical nuances, I thought we'd play like a little bit more of a game here. I'm going to tell you about one of the ones that I've had, but it's kind of tell me about the strangest thing you thought was going to be one thing and turned out to be another. So, and because I think this will highlight for our listeners some of the strange communication things that happen and where it can highlight, it's really the communication between physicians that is the game changer for so many of our patients and their diseases.
Mm-hmm.
So I'll give you an example. I had drawn a picture of a lesion. I can't remember even what the original, it was some sort of conjunctival granulomatous lesion that I was unsure of the etiology. And I'd drawn a little picture of it and I drew the eyeball and I thought I drew a pretty good nose. And I described it and I said that it was rapidly increasing in size. And when I got the report back, it was talking all about the urethra. And I was like, I don't think we have those in the eye. And I called the pathologist and they're like, there's been a mistake here. You're right. I can see the eye. I can see that we'll go back and we'll review it because the report didn't match with what my kind of, what I had sent. Now I can't remember what the actual point of confusion was, but I want to know the strangest thing you've had sent to you that you thought was one thing and it turned out to be another. And I'm also curious about, I feel like I would be remiss in this podcast if I didn't mention one of my mentors, Dr. Val White.
Oh, yes.
Val was obviously still working when I trained, and she had such a tremendously active role in our training. We would show up at pathology rounds every Friday, and she'd have slides out, and she'd be like, Homer Writer, Flexner, Wintersteiner, don't get it wrong, O'Donnell. No, she wouldn't be that. But, she was insistent that we knew, and we would all occasionally have specimens that would have like strange foreign bodies. So tell me what have you seen inside eyeballs when you've cut them open, or have you had any surprises that come to mind in terms of pathologies?
First of all, addressing your original point, the urethra has a caruncle.
Oh, so I bet you I described a caruncular. Yes. Yes.
And the other thing is that many pathologists use Dragon dictation, or we use a medical dictation software. And the medical dictation software will often default to what's common elsewhere and miss eyes unless it's trained. So, no, I totally agree. I mean, one of the funniest, it was more on a report that I had a colleague of mine. I read temporal artery biopsies in Ottawa. That's another interesting situation too. But anyways, my colleague signed out a pathology report as temporal arteries, left and right, and she'd use a dash, negative for arteritis. Got a call from a clinician, and the clinician said, now, I just want to clarify this. You've got a negative and a negative. Now, two negatives make a positive. So are you trying to tell me this is actually positive for giant cell arteritis? I go, oh, dear me. No, I said, I think somebody had a bad day. But anyways, we stopped using dashes as a result of that. I mean, if you read pathology reports as well, we tend not to say there's no cancer. It's all negative for cancer because no's get dropped by dictation modes all the time. Yeah. So I've seen conjunctival papillomas, squamous papillomas, be malignant melanoma.
Oh, wow.
So that is not an unusual diagnosis. My temporal artery story, I mean, I just had a recent case of where I'm working where a gentleman presented with an aortitis. that was picked up incidentally at the time of aortic surgery. And because it showed a giant cell granulomatous appearance, they suggested probably doing temporal artery biopsies. Serology was completely negative, no symptoms, no visual loss, and positive biopsy.
Isn't that
So
amazing?
it's like just when you think you've seen it all.
For our listeners, the giant cell arteritis is a condition that it's one of our emergent conditions in ophthalmology, where if a patient, especially in their more elder years, if an older adult presents with a headache and sometimes transient or sometimes total vision loss, this condition can irreversibly blind patients, and it can happen in both eyes. And in many patients, if intervention is rapid with anti-inflammatories, we can either resolve or at least prevent further vision loss. So that's a really critical example of the link between how rapid access to anatomic pathology can really make the difference and be a game changer for patient care. I'm very fond of the time that I spent in learning ophthalmic pathology with Dr. White and Dr. Rasmussen out here at UBC, and the engagement of, I think one of the challenges as well as we move forward in resident education, if we don't have dedicated ophthalmic pathologists passing on knowledge in an organized way to our residents, I think there's going to be limitations in their ability to learn and acquire necessary knowledge for, even if they don't become anatomic pathologists or diagnostic molecular pathologists. Sorry, I should get that right.
Yeah.
There are so many things that are critical to my care of my patients. When I'm curious about, could this be lymphoma? I hear Val's voice in my head saying, Heather, you better call me and know whether or not you should send that fresh. And I think that that's such an important, it was such an important and valuable part of my training that I'm so grateful for. Not that I'm perfect at it by any stretch of the imagination, but I think that it was really critical.
Well, I think, if I'm looking at a pragmatic approach to ophthalmic pathology to residents, and I stress this with the anatomic diagnostic molecular pathology residents and ophthalmology residents, is communication, right? If you as an ophthalmologist send off a specimen and you get a result back that doesn't match what you think, you need to call the pathologist. You need to have a discussion with the pathologist because, from a pragmatic point of view, a pathology report needs to be interpreted in light of the clinical finding. If the pathologist makes a mistake and calls something benign that's cancer or vice versa, that's clearly wrong, and you accept the result of that pathologist, you are partly responsible for the demise of that case and medical legally. Because a pathology report sits like a radiology report, sits like a blood test, in that it's a report to be interpreted by a clinician. And I tell the residents, for example, especially ophthalmology, if, you back in the day when we did routine CBCs before cataract surgery, if you got a healthy 85-year-old woman sitting there and you get her CBC back and it's hemoglobin of 4, are you going to admit her to hospital and transfuse her 5 or 6 units? Or are you going to assume it's an error and repeat the test? That's a no-brainer, right? Well, a pathology report's the same thing, right? Yeah. We will interpret what we see based on what you tell us, and whether it fits the whole clinical scenario. And especially in a niche subspecialty, it becomes especially important. And that's why, good communication is critical. And I think that's you highlighted. And that's what I try to instill in people is that, pathologists like to talk to people. I'd rather hear from a clinician that this doesn't fit and maybe I made a mistake rather than from the lawyer or the plaintiff.
No doubt. No doubt. So tell us about, can you tell us a little bit about COPS? I know we've chatted about a lot of different things, but what is COPS and what's the work that's being done?
COPS is the Canadian Ophthalmic Pathology Society. It was started many, many, many years ago. Seymour Bronstein, Miguel Bernier, Godfrey Heathcote, Val White. I mean, all my predecessors who built the society up from just an interest group to an official meeting that then, thanks to the COS, closely aligned us with the annual meeting. And so it's the meeting the day before the COS starts. And it has evolved over time from just the select group of ophthalmic pathologists interested, maybe 12 or 15 presentations of interesting cases, To this year, I've probably got close to 30 presentations that have been submitted, and the number seems to grow every year. We have a dedicated group of oculoplastic surgeons, anatomic pathologists and pathologists, ophthalmic pathologists who send in cases, and we discuss them over the course of a day. And we have an international expert who comes over. It gives us a half-hour update on something that's important in our field, and then actually then participates in the day. And since I've been doing this, I took over for Val. It was Godfrey Heathcote for the longest time, and unfortunately, he did pass away, and we were very sad for our loss and his families. Then it was Val. Then I took over from Val, and the numbers of presentations and the interest in this has just gone, through the roof. And all the international speakers that we've had all compliment us on how well presented these cases are. It's residents and fellows and occasional medical students. They are really quite impressed with the exuberance and the skill and the intelligence and the conversations that we have around it. It's a nice, I wouldn't say totally informal, but people aren't afraid to stand up and give their opinion and maybe have a little bit of a discussion. It ends up being a wonderful time. I mean, we get to the point where we almost need another day.
Well, I look forward to attending this year for sure. Before we wrap up tonight, I do want to take an opportunity. We like to, on the EyeCan podcast, we like to take a moment to ask our guests to tell our listeners something about them outside of this realm of medicine. Tell us something about yourself that the story so far hasn't told us. Tell us what you like to do, something you enjoy outside of work.
Oh, well, I mean, I swim regularly.
Okay.
I'm in a master's group, although I am not a master swimmer. And I like outdoor sports, biking and cross-country skiing. Downhill, thank goodness, my hips have prevented me from doing that because I'm not good at it. But I think one of my real passions, and I got this totally through my wife, is backcountry camping in the summertime.
Oh, wonderful.
Yeah,
Tell me, where are your favorite places to go? Have you done any backcountry camping in BC?
No, unfortunately, we've been just really relegated to Ontario and Quebec. Okay. But as we're getting on in our careers and having more time off, the idea is to spread it further west. But it's Algonquin Park, which is not very far from Ottawa, and Killarney, which is one of the most beautiful provincial parks in the province of Ontario. It's right on Lake Huron. It is magnificent. It's also incredibly difficult to get a spot, but we figured out a little way to do it. But it's just, we've got light solo canoes, so you can portage these things easily no matter what age. You're by yourself, you use a kayak paddle, and then we go one or two portages in, and you spend 2 or 3 nights completely away from everything. It's remarkable.
Magical.
Yeah, it is. It truly is.
Bears, moose.
Well, but bears, as I like to tell people, knock on wood, I've only seen bears at a very, very far distance. If you go backcountry camping, certainly, I'm sure it's probably the same in BC, and black bears are different than brown bears, although everybody says they're not. I think they are. They're not habituated to people. So the further you go in, the more likely they will be afraid of you than if you car camp, where people dump garbage everywhere. Those are nuisance bears. Those are problematic. But when you tend to go way into the lake or 2 lakes past that portage, if you do run into one, heaven forbid, but we have bear spray, but I think they'd be more afraid of us because they're not used to us, because they're too, they're isolated, and other than that, other than, squirrels, chipmunks, the occasional snake periodically, but they're not poisonous, doesn't matter. Snapping turtles in the water. Have a couple stepped on a couple of those. But it's so relaxing and so nothing better to me in the morning than waking up, having a cup of coffee, sitting on a chair, looking out over a lake. And I don't fish. Another thing is, if you were to fish, it'd be better.
I think you're a perpetual observer in this space. You, whether it's at your work or out in nature, you enjoy taking things in and observing what's around you. So that's very interesting.
It's interesting. I get medical students, people wanting into medicine, wondering what does it take to be an ophthalmologist? I said, listen, what it takes to be an engaged human is to be curious. If I say one criteria that I would want any medical student or ophthalmology resident, pathology resident to have is be curious about what you do. Because if you're curious, you're going to learn and you're going to care. And once you've conquered that, it makes life fun. It makes what you do fun. And we should enjoy what we do. We're privileged to be able to do all of this. But gosh, if you lose your curiosity and it becomes tedious, yeah, you can make a living at it. But is that really what it's about? I don't think so.
Oh, what special advice. Yes,
Yeah.
I couldn't agree more. And I'm so grateful for the opportunity to have been able to chat with you tonight. What a pleasure. I'm sorry we haven't met before in person, but I look forward to meeting you in person sometime soon.
Okay. Well, my pleasure all mine. And thank you, Heather. Glad to meet you too.
Thank you for joining us for this episode. We look forward to bringing you more engaging content over the coming months. EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Season 5 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado EyeCan vous est offerte par Bayer. Nous les remercions pour leur soutien.
Thank you from the Canadian Ophthalmological Society. EyeCan is available wherever you listen to your podcasts and, of course, through the COS Practice Resource Center.
EyeCan est disponible partout où vous écoutez vos balados et bien sûr au Centre de ressources pour la pratique de la SCO.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan est écrit et réalisé par Kim Teitler et produit par John Allaire d'Allaire Strategic Works. Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more. Certains épisodes de cette saison incluront des liens pertinents dans les notes d'émission, alors n'oubliez pas de consulter les descriptions des épisodes pour en savoir plus.
If any of our listeners have topic ideas to submit, please email them to communications@cos-sco.ca and we will review for consideration.